As Scott had said, we're going to present on geriatric sleep issues today. We'll do the next slide. So the objectives today are recognizing the importance of sleep disorders in older adults and evaluation and management of some of the more common sleeping problems in older adults as well. Next slide. So the specific topics that we'll cover will include sleep epidemiology, age-related sleep issues, specific sleep issues, insomnia, sleep-related breathing disorders, periodic limb movement disorder in sleep, restless leg syndrome, circadian rhythm disorders, overall changes in sleep with dementia, sleep disturbances in the hospital and long-term care settings, and some treatment pearls. Next slide. All right, so in recognizing the importance of sleep disturbance, it's linked to an overall poor quality of life, cognitive decline, increased risk for a major depression, and studies show that insomnia is an independent predictor of death and nursing home placement. And then looking at the secondary risks that come with poor sleep. Often patients can be found or seen to be self-medicating with alcohol and over-the-counter medications to help with sleep, which come with their own set of risk. Next slide. All right, epidemiology. Primary sleep disorders that increase with age. Sleep-related breathing disorders, restless leg syndrome, periodic limb movement disorder in sleep, circadian rhythm disorders, insomnia. All of these increase as we get older. In fact, 30% of people over the age of 65 will struggle with insomnia in some capacity. And roughly 5% of older adults use some form of prescription sedative hypnotics nightly. So that would be like Ambien, Sonata, Lunesta. More common in older African Americans, particularly women and in those with depression and chronic illnesses, have sleep issues. Treatment of depression may improve the sleep abnormalities as well. Lack of attention to sleep complaints in older depressed adults can make treating depression less likely to respond to treatment. And in clinical practice, we work with a lot of folks who have mood disorders. And one of the reasons why a treatment program may not be working is because they're just not sleeping well on top of their mood issues. Next slide. Okay. And so as we've talked about risk factors for sleep issues, age can be a big one. As we get older, more chance possibility for sleep disorders to develop. Patients with multiple chronic comorbid conditions have an increased risk for sleep issues. As we get older, we're just less physically active, and the less physically active we are, the more trouble we can have with sleep. It disrupts our circadian rhythm. Physical disability can impact sleep, and pain as a risk factor for poor sleep as well. Next slide. All right, so why is sleep so important? The functions of sleep are restorative, help with cellular repair and maintenance of our immune system. It helps lower cardiovascular risk. It boosts our mood. Clearance of neurotoxic waste, and brain plasticity and learning. Sleep is when we're committing things to memory, building the synapses on the day's events. Next slide. Okay. The sleep stages and sleep requirements. Adults over the age of 65 require about 8 to 9 hours of sleep a night. And our sleep is broken up into non-REM and REM sleep. So the cycles with non-REM sleep is how we start. N1 is the transition to light sleep. That's when you're lying in bed and you're kind of drifting off. The light sleep is about 5 to 10% of our overall sleep for the night. And then we transition into N2, which is maintenance. It's a little bit longer, 45 to 55% of our sleep time is N2 sleep. And then we transition into N3 or deep sleep, about 10 to 20% of our overall sleep time. And then REM sleep is 18 to 23%, and that's where we have some of our dreaming, memory consolidation, and pruning of old memories. REM sleep increases and N3 deep sleep decreases with each cycle throughout the night. Next slide. So as we get older, our sleep architecture changes. Our total time of sleep decreases. The latency, or the amount of time it takes to fall asleep, increases. Our sleep efficiency decreases, so that's the time that we're asleep versus the time that we're in bed. The propensity for daytime napping increases, and the more daytime napping we have, the harder it is to fall asleep the following evening. N1, N2 lighter sleep increases, our N3 deep sleep decreases, and our REM stage sleep decreases as well. So overall, as we get older, we're less resilient to sleep changes and disruptions to our sleep, because a lot of our time is spent, more time is spent in N1, N2 light sleep. Next slide. Right. So when we're evaluating patients for sleep disturbances, the biggest thing is, are they satisfied with the quality of their sleep? And often when I'm seeing patients in clinic, their spouses will bring up the complaints or the issues before the patients do. Tell them about the time when you're kicking me at night. I keep telling you that, you're doing funny things in your sleep. In 9 years of practice, I have probably yet one day to go by where we don't talk about sleep in some capacity, whether it's insomnia or I have sleep apnea or my wife thinks I have sleep apnea type of a deal. So how does our sleep issues negatively affect our daytime activities? Do we have a lot of daytime fatigue going on? So getting collateral information from family members can be very important. Next slide. So other ways that we can evaluate sleep is through a sleep log, and there's lots of examples online where you fill out, how many hours of sleep you think you're getting when you go to bed, what time you're getting up, and you can start to identify some patterns if you plot it out like that. But I'll tell you that I had a lot of patients, or recommended to a lot of patients to look at this, and I don't think I've had anyone return that information. Focused physical history and exam guided from the history is an important piece. I look at this with sleep apnea. Some of the bigger folks with, thicker necks are at higher risk for obstructive sleep apnea. But are there other things? Are they chronically fatigued? Are they bleeding? Is iron deficiency at play, which increases the risk for restless leg syndrome? So doing a good history and physical exam will kind of help guide, do we have a true sleeping disorder going on here? Mental status testing, focus on memory and mood problems, depression. Folks with depression, folks with dementia often will struggle with sleep deficits in some capacity. Lab testing, again, iron deficiency is a big one for restless leg syndrome. Next slide. Another way to evaluate sleep is through polysomnography. It's indicated for primary sleep disorders are suspected, sleep apnea, narcolepsy, geriatric limb movement disorders, REM sleep disorders, which is violent or unusual behaviors during sleep, or when sleep symptoms are not responding to typical treatments. Now, with sleep apnea, there's a newer version of in-lab testing. You can do this at home now, which has been around for a number of years. And I still find it interesting how many patients are not aware of this. And a lot of patients were resistant to being worked up and tested for sleep apnea because they didn't want to go in for an overnight sleep study lab, but are now amenable to do the portable home monitoring. It's not quite as sensitive in diagnosis. It really catches some of the kind of black and white cases, but it's a great screening thing, especially if you're having trouble getting somebody in to commit to a sleep lab. The wrist scintigraphy activity monitors, you can find a lot of these on your Apple Watches these days. They will estimate your sleep wakefulness and can really be helpful in trying to identify some circadian rhythm disorders. Next slide. Okay. So insomnia is a very big sleep issue. As before, up to 30% of people over the age of 65 will struggle with insomnia. The DSM-5 criteria defines insomnia as difficulty in initiating or maintaining sleep, waking up too early. Symptoms must occur for at least 3 times a week. And for it to be chronic insomnia, they must be present for at least 3 months. Risk factors for insomnia, gender, females are more prone, social isolation, polypharmacy, over the age of 65, these patients are on multiple different medications, and interactions can cause insomnia. People who are depressed or have anxiety can often have trouble sleeping, and caregiver stress. So not only the patient with dementia, but their spouse who's caring for them may struggle with sleep, just from the overall demands that requires. Next slide. Okay, so the complications of insomnia, fatigue, daytime impairment, poor concentration, and that we're at risk to develop treatment-resistant depression. And studies show that these folks are at increased risk for suicide as well. Next slide. Okay. So as we kind of alluded to, what is the risk factor, what brings insomnia on? Chronic conditions, pain, paresthesias with diabetic neuropathy that can often be worse at night, mood, alcohol, and as we mentioned before, patients may self-medicate with alcohol to try and get to sleep, and it may help initially, but it's a shorter, lighter sleep, more of the N1, N2, and over time that disrupts the sleep architecture and can create very treatment-resistant sleep improvement. Diabetes increases the risk for insomnia, acid reflux, nocturia, getting up to go to the bathroom multiple times a night. In the elderly, our sleep architecture is so fragile that anything that is causing disruptions we're awake and it's harder to get back to sleep. So if you've got the 70-year-old who's getting up 5 times a night to go to the bathroom, working that up and treating the BPH, enlarged prostates, can really have a positive impact on their lives. Cough, postnasal drip, these are some other things that can precipitate sleep issues. Other reasons why people struggle with insomnia, polypharmacy, that's the drug-drug interactions that make cause stimulating effects. Diuretics, again, having to get up to go to the bathroom overnight. Late evening or late afternoon caffeine, bronchodilators, activating psychotropics. So that would be like Zoloft or Prozac, are the SSRIs that are a bit more shown to be psychoactive activating. Antidepressants, some Parkinson's medicines, propranolol, and cholinesterase inhibitors can also cause some sleep disturbance, which comes with its own set of challenges. We're using these medicines to help with folks who have dementia and may help slow the decline. But looking at the risk-benefit ratio, if there's minimal to no benefit with the medicine, with their mentation, but it's causing sleep issues, are we really accomplishing anything? Next slide. Medications associated with insomnia, chronic use of sedatives may cause light fragmented sleep, and chronic use of sleep medicines may lead to tolerance and dose escalation. I'm currently working with a guy in his 30s who's working through pretty significant depression that was abusing alcohol and had been on Ambien as well, and started abusing the Ambien. He was using up to 30 milligrams at night just to try and get to sleep. And he described it to me as he felt like he was being tortured because he couldn't sleep. So he was trying to do anything and everything he could do to try and get to sleep. And that can get to be a very difficult process to work through. Rebound insomnia can occur with chronic use of hypnotics if they're suddenly stopped. So if you do have somebody who's been on them for a long period of time and wants to get off, or who is abusing them and we need to get them off, tapering it down instead of suddenly stopping is the way to look at that. As we've said, alcohol can lead to lighter sleep of shorter duration, so it's not a great, it should not be used for sleep issues. And sedatives and alcohol together is just a very bad idea, can worsen sleep apnea, and can even cause death. Next slide. Okay, sleep-related breathing disorders, central sleep apnea. The respiratory is absent or decreased. The central nervous system is not sending the signal to the respiratory system to do its job overnight. So you still have the periods of time where you quit breathing throughout the night, or you kind of make these weird gargling noises at times through the night. It can be a primary disorder by itself, or a secondary disorder due to a neurodegenerative disorder, stroke, heart failure, dementia. Initial treatment should focus on the management of the underlying disorder. So if you've got somebody who has heart failure, if their heart failure is not well managed, sleep issues can be a byproduct, and treating the heart failure will improve the breathing disorder. And then using CPAP device, positive airway pressure, is integral in sleep apnea. Next slide. Obstructive sleep apnea, that's when the there's an obstruction in the airway, which disrupts our breathing efforts, or it disrupts our ventilation. The drive to breathe is still there, but there's an obstruction in the airway, so we're not ventilating as we normally would. So these are the folks that this increases with age, obesity, the thicker necks. The elderly, however, may have a normal body mass index. So in the younger years, we have the prototypical person, morbidly obese, the thick necks, snoring, but the elderly may present a little bit differently. That being said, one of the ways that we assess this is through the Stop Bang questionnaire, and I think that'll be on this next slide coming up, but that's a way that we can assess in the elderly, even if they don't present the way that we would expect. Untreated sleep apnea of any type is going to cause daytime sleepiness, a headache in the morning. You've got a little excess carbon dioxide built up, and when you get up, you've got this headache as a result. And when you've been up moving around, you're expelling the rest of that, and the headache will dissipate. Untreated sleep apnea can cause personality changes, poor memory, confusion, and irritability. And that's an important piece, because if you have a patient with dementia who can't necessarily tell us, what's going on or why they're irritable, sleep apnea may be at play. Often the patient is not aware that they have trouble breathing at night, and this is where collateral information is important. I would say at least 50% of the time the patient says, my wife wanted me to tell you, or the spouse is in the exam room and they say, he makes weird noises at night, or he's kicking me. So these are things that the patient themselves may not be aware of. And as we've said before, diagnosing sleep apnea requires polysomnography in home or in lab study. Next slide. So clinical suspicion for sleep apnea, the large BMI, large neck circumference are independent predictors. People who are falling asleep at inappropriate times or having a lot of daytime napping. Males are more at risk than females. And in folks who don't present the way that I would expect them to, treatment-resistant hypertension, or even just having a diagnosis of hypertension in somebody who I wouldn't expect it, is often where I'll find sleep apnea. This is somebody in their 30s who has no family history of hypertension, and they're of normal weight, but yet, their blood pressures are 150s over 90s consistently. Treating the sleep apnea, and now their hypertension has pretty much gone away, is something I've seen multiple times. Unexplained atrial fibrillation. That's another, clinical clue that this person may have sleep apnea. I have a personal friend who was admitted for heart palpitations, found to have atrial fibrillation. Overnight, they noticed oxygen desaturations and said, "Oh, you may have sleep apnea." He was subsequently tested and had severe obstructive sleep apnea. So that's another clinical clue. And it's important to treat sleep apnea if we have it, because atrial fibrillation and all the sequelae that comes from that, it increases the risk for cardiovascular disease, cognitive decline, motor vehicle accident risk is higher, especially with that from that daytime sleepiness, and really just increases all-cause mortality. Next slide. And this is an example of that Stop Bang questionnaire. You can find this pretty much everywhere. I have a dot phrase for anyone who's used Epic to put this into my notes. But this does a really good job at estimating the risk. So anyone who's at intermediate high risk definitely should be screened for obstructive sleep apnea. But I've had a few that scored on the low end that I still had a high clinical suspicion that I still sent for testing and came back positive. So definitely a good tool to use. Next slide.
Judy.
All right, other sleep-related breathing disorders. So as we talked about, positive airway pressure is important with treatment or diagnosis. And contrary to what some people may think, older adults are just as likely to tolerate CPAP machines as well as younger adults do. You know, the benefits of treating sleep apnea are well known and really just improve overall quality of life. And the earlier somebody gets used to using the machine, it does have a positive predictor on long-term adherence. And what I find is having people lay in bed with it for 15 minutes at a time and then trying to use it for the night, and then the next night maybe have it on in bed for 20 minutes before trying to go to bed, and then just increasing that time will help people get used to it. And sometimes you do need some sleep medicines initially when you're using the CPAP, and that will just kind of help with compliance. Next slide. Okay, periodic limb movement during sleep. That's repetitive leg movements that occur during non-REM sleep. This increases with age, and we can see this in up to a third of long-term care or skilled nursing facility patients, possibly related to delayed motor and sensory latency, as shown on EMG nerve conduction studies. Periodic limb movement disorders, that's sleep disturbances that are causing fatigue that are not explained by another sleep disorder. Diagnosis for these requires polysomnography. Next slide. Okay, restless leg syndrome, it's an unpleasant urge and sensation to move your legs or arms. It's usually present at night, but it can happen during the day. And it improves, that unpleasant sensation or urge improves with movement. This is something that we can diagnose based on clinical description. Many patients who have this condition also have periodic limb movement syndromes. There's a family history genetic component to it. Females are at higher risk than males. And certain medications may increase the risk for restless leg syndrome as well. SSRIs, antiemetics, tricyclic antidepressants, Benadryl, antipsychotics, and as we talked about before, low iron. Next slide. Okay, treatment is indicated for restless leg syndrome if the symptoms are severe or impact your quality of life. Non-pharmacotherapy wise, you know, work up and treat the iron deficiency, avoid aggravating factors. That's long car rides can increase the risk for it. So try not to sit in that recumbent position for long periods of time. Daytime exercise, leg massage at night before bed, heat can also help reduce the incidence of restless leg syndrome overnight. And for intermittent symptoms, these are the ones that are precipitated by long car rides or short, infrequent flares at bedtime. Carbidopa, levodopa, as needed at bedtime, can sometimes help with these symptoms. People who have chronic symptoms of restless leg may benefit from Mirapex or Requip as a first-line treatment. We can use gabapentin off-label who don't tolerate the dopamine agonists. Benzodiazepines and opioids, off-label or not, are just rarely used. They can be used off-label, but they should not be used in the older adults due to the risk of adverse effects. Next slide. Circadian rhythm sleep disorders. This is disruption of the sleep-wake cycle. Prevalence of this increases with age. Advanced sleep phase, we fall asleep earlier and awaken earlier. This is what we see in our older folks. The delayed sleep phase is we can fall asleep late and awaken late. And you see that common in dementia or nursing home residents. And disruption in circadian rhythm disorders can be quite severe. Next slide. Okay. As we've talked about before, the sleep logs and the wrist actigraphy can be helpful to establish these diagnoses. And treatment really depends on the particular circadian rhythm disorder we're looking at. Advanced sleep phase may respond to the evening exposure to bright lights, and the delayed sleep phase may respond to morning exposure to bright light, or using some melatonin in the evening. Sleep specialist referral is recommended when symptoms don't respond to the initial management, or if the diagnosis is unclear, or when there's another sleep disorder that may be happening in conjunction with this. Next slide. REM sleep behavior disorders. This is excessive motor activities during sleep and pathologic absence of normal muscle atonia during REM sleep. This is another one where the spouse in the exam room will say that, you know, Henry's hitting me, or, you know, kicking, and, you know, can, to the point where they're causing bruises on their spouses. This familiar predisposition can be associated with Parkinson's disease, Lewy body dementia, and, you know, this may contribute to caregiver stress from the spouse who's caring for the patient with dementia. Polysomnography is needed to establish this diagnosis as well. Next slide. Treatment for REM sleep behavior disorders, if it's drug-induced, remove the offending medication. Environmental safeties are indicated. So, you know, if bed rails need to be present, you know, so that people aren't falling out of bed, may be a good idea too. Melatonin, there's some evidence to suggest or support its use in older patients who have Parkinson's or Lewy body dementia. Clonazepam off-label can be used in younger people for this condition, but the use in older adults, it may help with treating the REM sleep behavior disorder, but it may also increase the risk for cognitive issues, falls, hip fractures, other issues. So typically we wouldn't use this with somebody in the elderly population. Next slide. Okay. Changes in sleep with patients with dementia. Older patients who have dementia often have more sleep disruption and arousals. They have lower sleep efficiency. They have that higher percentage of N1 sleep, which is that very light sleep, and they have more sleep fragmentation. Disturbances of the sleep-wake cycle are common with patients with dementia. So they may have excessive daytime sleeping, nighttime wakefulness, agitation. Next slide. Managing sleep issues with patients with dementia. So nighttime use of cholinesterase inhibitors may make insomnia worse and can cause vivid dreams in some patients. And that's that whole risk-benefit ratio. Are we really getting the desired benefit with the medicine? Maybe, maybe not. But if it's causing sleep issues, you know, we make a case for stopping the medicine. Sedative hypnotic agents have not been adequately tested in patients with dementia. You know, in general, we try and avoid these. In patients with both obstructive sleep apnea and mild to moderate dementia, positive airway pressure can still be well tolerated and can still improve sleep apnea symptoms and may have beneficial effects on their cognition. And daytime bright light exposure can be beneficial in re-regulating or returning this circadian rhythm back to normal, and is a safe intervention. Next slide. Okay, sleep disturbances in the hospital. Factors contributing to insomnia in the hospital, you know, the illness that's causing them to be in the hospital. Medications change from their usual nighttime routines, so that really creates a disruptive circadian rhythm. And then just overall disruptive environment in the hospital. Nursing assessments, vital sign checks, you know, depending upon which units folks work on. You know, you've got bed alarms going off in the middle of the night. You know, the overall activity at night can cause sleep issues in folks. And the more sleep deprivation we have in the hospital, it can increase the risk for delirium. And delirium may lengthen hospital stays. Next slide. Okay, so what are some ways that we can help improve sleep in the hospital? Non-pharmacological interventions may be helpful, so daytime bright light exposure. Change medication times to allow patients to sleep later in the morning, so have more flexible medication administration times. And there was a feasibility study that compared back rubs, warm beverages, relaxing tapes at night against medications, and there was some data to suggest that, you know, those non-pharmacological measures are just as good as medications to help with sleep. Now, I've worked in the hospital for many years, and I don't know that you'd be able to find anybody I'm surprised they found nursing staff to participate in this study to be giving back rubs and stuff. Who has time for that? But apparently there's some benefit to it. Next step, or next slide. Okay, benzodiazepines are commonly used for sleep disturbance in the hospital. We should try and use smaller doses. If we're using this for an elderly patient, and if we do need to use a benzodiazepine, it should be the smallest effective dose. Sedating antihistamines, Benadryl should not be used. That's a very common theme throughout. Antihistamines increase the risk for falls and cognition issues over time, or daytime oversedation the following morning. And these medicines increase the risk for delirium, urinary retention, basically all of their cholinergic adverse effects. Melatonin is not FDA approved, but has been shown modest effectiveness at bedtime for elderly patients in the hospital. Next slide. Okay. Sleep apnea is common in hospitalized adults, particularly in those who have cardiac illnesses, history of stroke. Elderly patients who are hospitalized should have their sleep apnea machines with them or have some form of positive airway pressure when they're hospitalized, especially if they're going to be given some form of sedating medicine or if they're using post-operatively recovering from anesthesia, that type of thing. Next slide. Long-term care settings, again, can be a place for a lot of sleep issues, physical illnesses, psychoactive medications, debility, inactivity. Large amount of time spent in bed during the day can really disrupt one's circadian rhythm. So there's higher prevalence of sleep disorders in long-term care settings. And then you have the same things as in the hospital with nighttime noise and disruptive nursing cares throughout the night. And then really a lack of exposure to bright light during the day. And depending upon why they're in the long-term care facility, you know, how much time or is it feasible for them to be outside or have some connection to bright light. Okay, next slide. Okay, so again, AM bright light exposure may improve nighttime sleep, reduce daytime fatigue and daytime agitation. Structured physical and social activities during the day, the more active we are during the day, the more our bodies will be ready to start the shutdown process at night to go to sleep. And then just really trying to decrease noise and disruptions throughout the evening and overnight. Next slide. Okay. Some more management for insomnia. Cognitive behavioral therapy is the recommended first-line therapy for all adults. And if the history and physical doesn't identify any other underlying cause, mild symptoms of insomnia may respond to a simple sleep hygiene. Chronic insomnia generally does not respond to simple sleep hygiene. Multifactorial approach with cognitive behavioral therapy and potential for medications as well. And one of the first things is educating patients not to participate in daytime napping because that will decrease your overall nighttime sleep. Next slide. So this is what sleep hygiene looks like. It really has everything to do with organizing your sleep-wake cycle and helps your body prepare for shutting down for the day. All of this is important, but I think the most important are limiting caffeine later in the day, no alcohol in the evening, going to bed at the same time every day, waking up at the same time every day, even on the weekends, and do something that's relaxing in the evening, but not overly stimulating. Textbook will tell you or show that, you know, no screen time within 30 minutes to 2 hours of bedtime. Technically, you shouldn't read in bed. Some people find reading to be very soothing. And I personally read 30 to 45 minutes before bed every night. That's really helped me sleep. They can watch a TV show or a movie as long as it's not overly active, engaging, mystery science, you know, thriller type thing. And some folks will find that that helps them get to sleep as well. Next slide. Okay, so this just is a graphic that tells us a little bit more about stimulus control, sleep restriction. This kind of delves into the sleep hygiene measures a bit more. You can read through that. Next slide. And cognitive interventions, relaxation techniques. Again, this is all ways to improve our sleep architecture. Can read through that. Next slide. Bright light, you'll have seen that throughout presentation. Really has good data behind it as far as helping to regulate the sleep-wake cycle, and can really help with folks who struggle with depression as well. So here kind of just goes through how many lux you need for how long, and how to use the bright light to help regulate the circadian rhythm. Okay, next slide. Okay, again, cognitive behavioral therapy is first-line treatment for chronic insomnia. It is effective in older adults just as it is in younger folks as well. Combining that with sleep hygiene yields better chance for symptom improvement. Typically, it's especially trained mental health professionals, psychologists, sleep medicine psychologists. But there's a wealth of data online and materials online that somebody can use to help with their sleep. Next slide. Okay, so if we are looking at prescriptions for insomnia, you know, we really want to make sure that we're treating any underlying comorbid conditions that may be affecting it. Short-acting agents are used for problems initiating sleep, but we can find more rebound and withdrawal symptoms after we discontinue them. Intermediate-acting agents used for problems with sleep maintenance, but we have more daytime carryover symptoms, oversedation, grogginess. And sedating antipsychotics shouldn't be used for routine management of insomnia for older adults. Next slide. Okay, so this and the subsequent slides really go through some of the class medications that one could possibly use, and you're going to see pretty much a common theme in these with respect to, yeah, maybe it helps, but what are the risks? And a lot of these are going to be similar with cognitive decline, psychomotor agitation, may increase the risk for falls, and there may be a role for them, but should not be used first line. Next slide. So zolpidem, Sonata is another one that could potentially be used for insomnia, but again, it increases the risk for falls, headaches, dizziness, abdominal pain, daytime somnolence. Next slide. Zolpidem, Ambien, again, another one that could be used, but potential for a lot of risk, falls, daytime sleepiness, impairment in driving, the hangover effect. And, you know, really with all of these, it's, again, should not be used first line, but if you are going to use them, what's the safest way? And as with any geriatric patient, you know, we start at a very low dose and work our way up. So start low, go slow type of a deal. 2.5 to 5 milligrams. Max dose is 10 milligrams, but, you know, really trying to avoid going above 5. Next slide. Okay, Ramotilon, again, can be used, but dizziness, muscle pain, headaches, Potential for rebound or withdrawal is possible as well. Rosarum is the other name for this one, if you've seen that. Casmetelanton, Ketalaz is the other name for this one. Can be used for insomnia, but has a long potential side effect profile to it. Typically, we would see this one more for non-24-hour sleep-wake disorders. So a blind patient maybe would benefit from this medicine. Next slide. Belsomra, orexin receptor antagonist. Another one that we can use, but again, carryover effects, driving issues, cataplexy-like symptoms have been reported with this medicine. Next slide. Doxepin, sedating antidepressant. You have somebody who has concurrent mood issues, it may be something to consider, but medicine has a lot of adverse effects again. Upper respiratory tract infections, nausea, sedation, and the central H1 receptor antihistamine is an active metabolite of doxepin, which is another reason that we may not consider this one because of just so many potential adverse effects. Next slide. Okay, mirtazapine, Remeron. This one is maybe a little bit more common for folks who have insomnia and concurrent depression. And it really is dose dependent because they work on different receptors in the brain. So 7.5 to 15 milligrams is typically what we would use for insomnia. But as we go higher in the dose, it more works for depression, mental health issues, and less on sleep. Okay, next slide. Trazodone, off-label use for sleep issues. It's probably one that I see a little bit more commonly used. It does have risk, maybe not quite as much as some of the other ones, but the orthostatic effects is really something to consider. A lot of our folks are on a lot of medications, antihypertensives, heart failure medications, and so precipitating orthostatic effects is really something to consider. Falls can be very, very traumatic. And so anything we can do to lessen the risk of falls is important to consider. Next slide. Okay, benzodiazepines for sleep. Really with this, it's just not a great idea to be using benzodiazepines for sleep. You have those special subset of patients maybe, but in general, it's just not a good idea. Okay, next slide. Okay, melatonin. A lot of folks will use this. It's over the counter. It's marketed as all natural. Insufficient evidence to recommend treatment for chronic insomnia for older adults. But it's maybe a little bit better than some of the other alternatives. And then sedating antihistamines, Benadryl is another one that we just should not do. Alcohol interferes with sleep later in the night and increases risk for falls. There's some data behind valerian root, kava. I've had a few patients ask me about this. I've had a few people that have used it and said it didn't help at all. But there is risk with some of these over-the-counter all-natural things. Hepatotoxicity is one, especially with kava. So even though these things are marketed as all safe and natural, your body still has to do something with them. You still have to metabolize them, and that can cause some issues. Next slide. Okay, choosing wisely, recommendations based on American Board of Internal Medicine. Basically, what this is stating is don't use benzodiazepines or other sedative hypnotics in older adults as a first line for insomnia for the reasons that we've talked about: agitation, delirium, falls, over sedation. Just in general is not a good idea. And again, there's that subset of patients that you may be limited to something like an Ambien, but we should be using the lowest effective dose for the shortest duration. And there is some studies or some data to suggest that if we're using them for situational insomnia, bereavement, the loss of a loved one that's causing insomnia, paired with cognitive behavioral therapy, counseling, there's maybe a role for a low dose sedative hypnotic for a short period of time to get them through that difficult time, but not as this is the medicine I use for sleep for years. Next slide. Okay, so in summary, sleep disturbance is incredibly common in the elderly. Our sleep patterns change. As we get older, we have more N1, N2 light sleep, and we're just less resilient to sleep disruption. In older folks, insomnia generally occurs comorbidly with other mental health or other medical conditions in general. So really identifying anything else underlying that's contributing to insomnia is important in treating that underlying condition. Cognitive behavioral therapy for insomnia is the first line treatment for chronic insomnia in all adults, including older adults. It can sometimes be a difficult sell. We want that magic pill that's going to fix something, tomorrow type of a deal. But there's really good data behind it. It's safe and it's effective. Polysomnography is indicated if a primary sleep disorder is suspected or if the patient is not responding to the prescribed treatments, and avoid high-risk sedating medications. That's a recurring theme, but we're really just trying to prevent falls and all of the sequelae that comes from that.